We recently published our experience from the US Multiple Myeloma CAR T Consortium, from 11 centers looking at CAR T-cell therapy in patients with renal impairment. Over a quarter of multiple myeloma patients at the time of diagnosis have renal impairment. It's a hallmark feature of the disease. Several more patients get renal impairment during relapse and as a side effect of treatment. So it's very important to look at this subgroup of patients with multiple myeloma. And these were systematically excluded from the original trial that led to the approval of ide-cel. So we looked at these patients, and yes, you have to adjust the dose of fludarabine, which is part of lymphodepletion, as fludarabine is renally clear. And this was a retrospective experience of fludarabine dose reduction was per institutional guidelines and did vary a little bit based on the centers that participated. With this limitation, though, we found that the safety and efficacy of ide-cel in patients with renal impairment is almost comparable to that, in patients without renal impairment. The only difference that we found was at day 30, patients with renal impairment had higher grade 3 or 4 cytopenias, but by day 90, this was similar. There was no difference in efficacy in terms of response rates or progression-free survival, no difference in other safety features, including cytokine release syndrome or neurotoxicity. And so I think what this tells us is that we should not hesitate to use our effective therapy of CAR T-cell therapy in patients with renal impairment. We even treated a patient with dialysis. We even had patients with less than a creatinine clearance of 30 ml per minute, and we did not have any patients going on to dialysis as a result of CAR T-cell therapy. So this is very safe. We should not hesitate, and I think we should broaden access to these treatments to all of our patients.